Our next speaker is Laina Lusk. Laina is a licensed certified genetic counselor at the Children's Hospital of Philadelphia. She sees patients with epilepsy, autism spectrum disorder, intellectual disability, and a range of other neurodevelopmental disorders in the Epilepsy Neurogenetics Initiative program. Laina saw her first patient with UGDH-related disorder in 2020. And I must say, I've interacted with a few genetic counselors and no shade on them, but as far as I can tell, Lena seems to be in a class of her own. Her practical knowledge, resourcefulness have been incredible assets to our scientific advisory board, and I'm so glad she can present on this topic today. So let's hear from Lena now.
Thank you so much for that wonderful introduction. It's been an honor working with you, and I feel very honored that I got to have a patient with UGDH so early when I started at CHOP. I think my first patient was actually born within the week of when I started. So UGDH has been a very special gene to me and has been a very special community. Um, so with that, I'll get started on just kind of talking through some genetics basics. Some might be review from biology class, some might be new. So feel free to just put questions in the chat and we can go through them. So first, a quick introduction to genes itself in UGDH. So our DNA is kind of the instructions for making a lot of the components in our body. It's packaged into these things called chromosomes, which get numbers or either X and Y. And then a gene is a certain section of DNA that generally codes for a protein. So DNA contains many different genes. A gene itself, again, like DNA, is just a set of 4 different letters, A, C, T, or G. So we kind of see our DNA here. If we kind of follow the process of making a protein, the next step is making mRNA. This is kind of like turning things into 3-letter words that the body then uses. So you can see there's slight changes in the letters, but it's broken up into 3-letter words, more or less. And then from there, we use those 3-letter words to make things called amino acids, which are sort of like the components that get put together in a final product or protein. And this is what happens. It all gets folded together and put together in a way that way makes our functional protein. So in this case, this is a picture from Dr. Simpson's lab of the UGDH protein. So an analogy for this whole process is sort of like using a recipe and baking a cake. The DNA itself is like the recipe that has all the instructions. You then use it to grab all of your ingredients from these 3-letter words, and then you put it all together to make your cake, your final product. So changes in your instructions in your recipe can lead to changes in your final product or your cake. So in this case, this protein, this product is called UDP glucose dehydrogenase, and this is what's called an enzyme. So it helps transform one molecule in the body into another. And it has a lot of important functions downstream. The things that it makes are really important, but some of the things that's really important are for embryonic development, so the creation of the early embryo. It helps with detoxification and removing harmful chemicals. It helps cells communicate with one another, and it helps the organization of cells, of telling each cell and component of where to go. So this is another picture just from Dr. Simpson's lab of showing this process in the more technical terms. But again, a way to kind of think about it of just a simple analogy is we have a person or a component in the body, and UGDH helps equip it for further jobs that it can do. So because of the way that it gets equipped, it can then help direct traffic, that each thing can kind of have a place to go, and it helps build the structure of the brain that each thing gets to its correct location. It can help with communication between cells and again, allowing signals to be in the right place at the right time. And then it can also help remove toxins and manage that. So it has a lot of important downstream effects. There's a lot of things that happen just from this first act of equipping with the right components that UGDH adds or helps add. So next we'll talk a little bit about inheritance and how genes are transferred to children, and that basic step there. So we all have two copies of the UGDH gene, and we get one from our mother and one from our father. So that's a pretty universal thing. We all should have two copies. And it's a 50-50 chance when we have our two copies of which one we pass on to our children. So it just is a continued process, like a coin flip of which one gets passed on. But everyone should then have two. In this case, for UGDH, you only need to have one copy working to keep you healthy. UGDH related disorder comes when you don't have any working copies of this gene. If you have one copy of the gene that is working and one copy of the gene that is not, that's called being a carrier. And this is something related to autosomal recessive inheritance. So to talk a little bit about this, again, a parent that's a carrier has one copy of the UGDH gene that is typical and working correctly, and one copy of the gene that is not working correctly. It has a change in that DNA that causes like that recipe to no longer work correctly. Your cake is not being made, it's not coming out correctly. But again, all they need is one copy to be healthy. So these carrier parents, they have a change, but they do not have any symptoms of the disease. And then it's like a flip of a coin, which copy they pass on when they have children. So you can have an unaffected child that gets both typical copies of the gene. So the one from their mother and the one from their father are both the copies of UGDH without any changes in it. You can have children that are also carriers, where they have one copy of the gene that works correctly and one copy of the gene that does not work correctly. So again, they won't have symptoms, but they have the ability to pass it on in future generations. And then finally, you can have an affected child, a child that has a UGDH related disorder, when they receive both copies of the gene that are not working correctly. So now they don't have any functioning protein and they have the related symptoms. So kind of to walk through the percents here, there's a 1 in 4 chance when both parents are carriers that you can have a completely unaffected child that is not even a carrier. So they cannot pass on this change to future generations because they do not have it. So again, 1 in 4, 25%. The chance that they have a child that is a carrier is a 1 in 2 or 50%. So again, sort of like flipping a coin there. And again, these people are able to have children that have a UGD related disorder if they have a future partner that is also a carrier. They themselves don't have symptoms, but there is a chance that it could pass on. And then finally, the chance that you have an affected child is also about 1 in 4 or 25%. And again, this is when they receive both non-working copies of the gene. So this is an important thing with autosomal recessive inheritance, is that there is this chance of it happening again of about 25%. There's other rare disorders where this chance is much higher or much lower, but for UGDH, it's 25%. So now moving on to talk a little bit more about these variant types. So what are these changes in the DNA that leads to someone having a non-working copy of the gene that can cause a disorder? So to kind of back up a little bit about this concept of genetic variants or changes, I'll kind of use this analogy of a sentence, which is sort of like what the DNA code would look like. So we might have the original UGDH gene could say something like, the gray cat ran down the hall. A benign or harmless change would be changing one letter in the word gray to be Grey instead of Gray. And so this means the exact same thing in English. I apologize that this is very specific to English and not other languages, but these two words mean the exact same thing. So the body, like you can read it exactly the same. It doesn't change the meaning at all. And that's why it's a harmless change. Another type of change is a pathogenic change, which is a harmful change, one that affects how the DNA actually works. And so this is like changing the letter A to the letter I. This no longer makes sense in English. This is not a word, Griy. So it now makes it causes a problem that this doesn't make sense anymore. And that's why it's called pathogenic. The final type of change is something called a variant of uncertain significance, or sometimes shortened as VUS or VOUS. This is basically an uncertain change, meaning we don't know what letter this is actually more like. Is this more like having an E that we can still read just fine, or is it more like having an AI that we no longer understand what it means? So it's sort of like a little question mark. We're not sure how to classify it. If you have a lab report, you might see these terms like uncertain significance, pathogenic, or benign. You might also see things that say likely benign or likely pathogenic. That just means that there's a greater than 90% chance that it's either pathogenic or benign. When it says just pathogenic or benign, that means there's a greater than 99% chance that it's truly pathogenic or benign. So the likely is just qualifying that it's not quite 99% sure, it's just 90% sure. So now I'll talk a little bit more about the different types of changes that you can see and what these mean. So one is a missense variant, which is where we swap one letter for another. So if in our sentence, this is like saying from the gray cat ran down the hall, we change that H and it says the gray cat ran down the ball. So this doesn't make sense anymore, but it is just one letter that's different. And in the DNA itself, it's like changing this letter U to be this letter A. And that changes the meaning of this three-letter word from TYR, which stands for tyrosine, to ASN, which stands for asparagine. What that looks like in a lab report is it might show you the position of where this is occurring. So it's the amino acid number 130. We expected to see TYR or tyrosine, and instead we see ASN or asparagine. So it just switched one of those words or one of those components for another. Another type of genetic change we can see is something called a nonsense variant. So this is where we essentially move the stop or like the period or end of the sentence to be too early. So instead of saying the gray cat ran down the hall, it just says the gray and it stops there. So we're missing the rest of the sentence. In this case, again, it can just be the switching of one letter, but the thing that it codes for is a stop instead of a different component. So it just ends early. And this is what this can look like on a lab report. Again, it tells you the position of where this happened. So position number 130, it tells you what we expected to see, which is this TYR. But then it shows this little either a star or an X to say it stopped. So that was the end prematurely. Another type of genetic change we can see is something called a frame shift variant. And this is where we move the way that we're reading these three-letter words. There's a shift, and sort of these spaces or gaps between words remain at the same place, but all the letters move down and now they don't make sense anymore. So in this case, it's like deleting this letter Y, but then moving all the letters down. So the rest of these are letters in order, but the words don't make sense anymore because we shifted where we're putting like our spaces between words. And in the DNA, it's sort of like removing a letter or adding a letter so that the rest of these are read incorrectly. And this is what this can look like in a lab report. Again, it shows you the position, it shows you what we expected. This will show what the first one was changed to. So in this case, it changed to MET or methionine because this went from here to here. But then it shows FS meaning frame shift. It'll usually show a star or an X to say that there's an early stop in however many amino acids down. So this is often what happens with frame shift. They often work a lot like those nonsense variants because they cause an early stop, but they cause some changes before that stop happens. Another type of change is a splice site variant, which is affecting the way that we put different pieces of the DNA together. So in this case, we might normally want to have red, yellow, and blue put together, and we cut out this green section because we don't need it. But a splicing change happens when there's a change at the point where we say, this is where you should cut, and this is where you should stick things together. And so instead, it'll accidentally put red, green, and blue together and make something slightly different, just because this instruction of where to cut and where to glue was different. So in a sentence form, this is kind of like if we had included accidentally a whole other sentence in the middle of our sentence, or we just cut out a big chunk of the middle of our sentence here. And in the lab report, this usually shows it's not quite in the part that of these amino acids. It's showing a part where we were cutting or sticking things together. So it'll look a little bit different, but it does give you the position of where it occurred, what letter in the DNA we expected, and what letter we saw instead. So then another type of, I think the last main type of genetic change we could see is like a deletion or duplication. So that's where there's a larger section of DNA that is either missing or it's repeated. So in this case for UGDH, it's more likely that we might see something that's a deletion where the whole gene is missing. And in the analogy of the sentence, it just means there's nothing there. The whole sentence is gone. And you usually get very like technical information, sort of like GPS coordinates of where the start and stop of that deletion is. So this just gives you information about where to look this up, the exact letter in the DNA or letter number that it starts and the letter number it ends, and then how many copies you have instead of the normal two. One other thing that can apply to any of these situations is something called mosaicism. So you might see this on some lab reports as well. So this is where some cells in the body have the change and some cells do not. So it can be different across different tissues. You might have more or less of that genetic change in the brain compared to the blood or compared to the skin. For individuals with a UGDH-related disorder that have mosaicism, they may be more mild because fewer of their cells have the change. This can also sometimes be seen in parents that are carriers. Again, it might mean that they are the risk of having a child with a UGDH disorder is a little bit lower because it's not present in all of their cells. So again, it kind of depends on the exact situation, but this is something that you can see and that might come up. So next, I'll talk a little bit more about these variants of uncertain significance or just uncertain changes, and how we try to figure out if they're actually an answer or not. So a laboratory will weigh out different pieces of evidence. There's lots of little things that they add together. Some of these pieces have more weight than others, meaning they make a bigger difference in whether or not we think something is harmful or not. One of the things that we do is we look for it in other patients. So if there's other patients that have the same exact genetic change, that makes it more suspicious that it is causing UGDH disorder. On the other hand, it can be present in the general population, and that maybe lots of healthy people have this particular change, which makes us less suspicious of it. You could have another genetic disorder or another cause for your symptoms that maybe makes us less suspicious that it's specifically UGDH. We can look at similar genetic changes, maybe other ones at the same spot, and see what they do. Are they harmful? Are they not harmful? We can look at how well the clinical presentation fits. Some symptoms are more common, like things like developmental delay. They don't get quite as many points as something that really fits the full picture that we're seeing these early seizures and other symptoms that go along with UGDH specifically. There are computer models that we can use as pieces of evidence. And then there's functional studies where we go in a lab, we look at the specific effects that this change is having on the protein itself. So sort of studying it in a lab setting where we can test it carefully instead of having to try to figure out what it's doing in a patient's body. So we have to weigh out all these pieces. Sometimes there might be some evidence in one category for a particular genetic change and then one's in the other. And we have to see if it weighs out properly, that we can give it a full classification of either benign or pathogenic. Otherwise, we get stuck in that uncertain category until we get more information. So one example here is that if you have a patient that has a really strong clinical fit for UGDH, we tested the variant in the lab and it looked to be harmful. We've seen this in other patients before. That can outweigh just seeing that maybe there was a similar genetic change that was not harmful. So we have a little bit of evidence in both directions, but it leans more towards pathogenic. On the other hand, we could have where computer models suggest that a change is pathogenic or harmful. But we might have a patient that has another genetic disorder that we think might actually be the answer for their symptoms. We might test the change in a lab and it looks like it's not harmful. And we can also see it maybe in control patients or healthy populations that have these changes. This set of evidence would then outweigh the computer models. But this is always a tricky thing. We're always trying to get as much information as we can, but sometimes we just need more time and more research to actually make this happen and to get enough that we can clearly tip towards either the benign category or the pathogenic category. So again, I just want to highlight this opportunity for the research study that we have going on, where Dr. Simpson's lab is actually studying these uncertain changes to see the effect that they have on the protein, so that we can use that as a piece of information to know if a certain uncertain change is actually the answer or not. So if you have a child with one of these variants of uncertain significance or VOS, and you'd like to participate, as Dr. Jamuar said before, you can contact Rebecca. There's the information that was shared on the link. But again, we'll take a look at the variant, decide if it's something that we think we should study, and then go from there. So I think with that, I wrapped up a little bit sooner than I thought. So I'll just have extra time for some questions.
Awesome. Thank you, Laina, for that great introduction to the genetics variants and classification criteria for UGDH. I'll ask a question. Will all sequencing labs give the same classification for the same variant?
That's a great question. And the answer, unfortunately, is no. They try very hard to be consistent, and there are a particular set of rules from a group called the ACMG that most labs try to follow. But sometimes some of the evidence is a little bit subjective of like how good of a fit is this for a particular presentation, and how many people in the general population is too many to say that this is actually harmful. So they often will be pretty close to each other. Many of the most commonly used labs will come up with the same classification, but sometimes there can be differences. Sometimes they weigh internal data that other people might not have access to, like they have actually seen a lot of other patients before. That other labs might not know about. And sometimes in different countries, they might use slightly different criteria. I've seen a lot of countries still, even outside of the US, still use ACMG criteria. But again, the way they actually apply the information can be a little bit different. I do think it's helpful having like a good genetics team in those cases, because they can kind of look at what different labs are saying, kind of look at the actual patient, the person in front of you, and be a little bit more specific in how we can apply those criteria. The lab doesn't really know the patient, so they have to kind of do their best, but sometimes the actual doctor or genetic counselor can have a better sense of that, if it's actually the answer or not.
You mentioned a number of different variant types: missense variants, nonsense, frameshift, splicing variants. Is there a particular type of variant that's particularly associated with this disorder? Or are there different variants associated with different presentations?
I don't think there's specific what we would call genotype phenotype correlations, meaning that one particular variant causes a specific type of disorder or a specific type of symptom. One thing that we do see is that this is often caused by loss of function. So, meaning the gene is not making a protein product that works. So, those nonsense and frameshift variants that cut it off early, or a full gene deletion, those tend to be much easier to call pathogenic because they are clearly disrupting the protein. Whereas the missense variants, sometimes they can still work correctly. So in the recipe analogy, like if you swapped sugar for applesauce, the the cake you're trying to make might still come out okay. It's just hard to know without testing it. Whereas if you just deleted 90% of the recipe, you know that the cake's not going to come out correctly because you're missing so much of it. Um, so I think there's kind of more to learn about how these particular variants affect the protein, and I think that's part of what the research that we're doing is going to try to look at.
Great. And then Dr. Simpson asked in the chat two questions. The first is, how frequently do patients have variants in more than one suspicious gene that complicates a diagnosis?
I think it's not uncommon. I think most of the lab reports that I've seen recently, it was pretty clear that UGDH at least was seemed more significant than others. I've seen lots of patients overall that have had maybe two or even three separate genetic disorders. So I think it's not very common, but it is quite possible. So I think it's always something just to check. A lot of those uncertain changes are very common. So sometimes people might have changes in UGDH and then an uncertain change in a different gene. Most likely, those uncertain changes are not harmful, but we always have to check.
You spoke to this a little bit, but it says, on a related note, how frequently do UGDH variants occur without having any pathogenic phenotype associated?
So a change in general, we all have lots of changes in our genes. So there are, I'm sure, many of those benign changes that can happen in UGGH. I think for I don't know, it's hard to quantify it. I think of the uncertain changes or ones that seem suspicious. Um, it can be hard to say. I think that if an individual has a pathogenic copy from mom and a pathogenic copy from dad, I would think that they will have the phenotype. But if they have a change that is uncertain and another change that's uncertain, it's much harder to say because so many of these changes are just normal, harmless changes. So I think it kind of depends on what evidence we have. Sometimes we can say a little bit more of like, there's a 10% chance this is actually harmful versus a 90% chance this is harmful. I think, again, once you actually have two harmful changes, there's a very high chance you will have the phenotype, but just a change without knowing if it's harmful or not is a much, much less likely to be related to phenotype.
I'll ask one more question. If a family has a report, say their child has a presentation that's very consistent with Jamuar syndrome, and they have one or maybe two variants that are classified as variants of uncertain significance, what should be their approach aside from enrolling for Dr. Simpson's study? What should be their approach? Should they continue to look for answers, or should they pursue that clinically, or how should they approach that?
Yeah, that's a great question. And this is something that definitely comes up for people a lot. I think, again, having a team or other people you can check in with can be helpful because they can assess from their clinical perspective what's the chance that this is actually the answer. I think it depends if like there's something else found. Were there other complicating factors, like maybe someone was born really prematurely or there was a stroke or something else? Um, and what little pieces of evidence do we weigh? Is this really close to being pathogenic, or is it actually really close to being benign, but even though it's still in that kind of uncertain category? Um, I think, something like Dr. Simpson's study is helpful, just getting more information. But the other thing is just to kind of keep checking on things every couple of years. There's going to be more and more things that are published, more patients, more in people in the general population that get testing. So we usually recommend if something's uncertain to do like an update with the lab every 2 to 3 years, because there may be more information that's published by then, either to find a separate answer or to update the UGDH into something that's truly an answer. So I think it's a little bit of trying to pull all the information available right now, but then also coming back every couple of years and seeing what new information is available then. So I think it's a little bit of, does this explain things well enough that you want to treat it as a temporary diagnosis or working diagnosis, or is it not quite enough fit, or it's not going to change anything, and you just kind of hold off? It depends a little bit on the clinical team and how they feel about that.
So I've got a question. Let's say parents are told by their clinician they have the genetic report, one or both variants are being reported as uncertain, but the clinician says, given some other factors, given your child's presentation, we believe that we can safely diagnose with this.
Mhm.
It doesn't seem like pursuing more functional testing will change much immediately for their clinical care. Why should they pursue that? What would be a reason to pursue additional testing on their variants?
Yeah, that's a great question. I think there's two things. One is more certainty about the diagnosis, because those uncertain variants are always tricky. They can go in different directions. So even if we feel really suspicious in one direction, it is reassuring when we can fully classify it as pathogenic or likely pathogenic. So I think, again, having more certainty for the diagnosis can be really helpful, because we don't want to kind of make big assumptions about that this is definitely the genetic cause and then refuse to kind of look at any other possibilities. I think on the other side, it can be really helpful for research purposes that if someone else comes along with the same variant, the more information that's already out there, the more functional studies that have been done can reduce that uncertainty for them. So I think there's, the benefit of clarifying like your child's diagnosis, but there's also then the ability to prevent that confusion the next time this variant comes up, because we have the full information. And we don't have to kind of go through as much guesswork of like, well, we think that this is probably the answer. If we have the functional studies, it can be easier to say, we know this is the answer just looking at this change.
And isn't it also correct that, let's say, um, a clinical trial opportunity opens up specifically for that genetic problem, if your variants are still getting classified as VUS, you might not be eligible to try that new therapeutic.
Yeah, that is possible. Every clinical trial is a little bit different about how comfortable they feel letting those uncertain changes in. But I think the more clarity you can have of the diagnosis, the easier it is for the pharmaceutical company to feel comfortable saying, this is definitely related to UGDH. So we definitely want to try our drug in this person. So, yes, I think that's definitely helpful. I think sometimes even having confirmation about what the genetic changes doing to the protein can also be helpful, of knowing this definitely causes the protein to just not be present at all. Then some of the clinical trials that come up that might be specific to that particular type of change or effect on the protein, we can know that that'll be helpful, where sometimes there's like different types of approaches that kind of depend on exactly what the effect of the change is. So I think in two ways is having that information could be helpful for clinical trials.